Hi, my name is Munya, and I'm a second-year resident in obstetrics and gynecology at Montfort.
Hi, everyone. I'm Dr. Justin White. I'm one of the gynecologic reproductive endocrinologists and infertility specialists at the Ottawa Fertility Centre and at the University of Ottawa.
So we have a 33-year-old female who presents to your office and says, "We've been trying to get pregnant and it hasn't happened yet. I'm worried something's wrong." When a patient comes in saying they're really trying to get pregnant and are worried something is wrong, what should be our first step as physicians?
Right. So, I think the first thing to think about here is what are our timelines? Some patients are coming in to be assessed because they're curious about their fertility. They want to check up. They might have some risk factors for infertility that may warrant more immediate testing. And others truly do have infertility. And a lot of times, the majority of an initial consultation or appointment when it comes to a fertility check is really about patient education and trying to get a sense of how much they know about the topic themselves. I would say, the first thing is to know the definition of what infertility is. And we separate infertility down between two different definitions. So one is primary infertility. So that's essentially someone who's never conceived before. And secondary infertility, which is someone who's conceived before, but now they're struggling. And it's a little bit more nuanced than that as well, in the sense of it depends on what kind of partnership that individual's in. In general, if someone's under the age of 35, where we think of egg reserve and egg quality being a little bit more protective, we would say the true definition of infertility is trying for a year or 12 months with regular menstrual cycles, assuming ovulation, regular intercourse, and no other obvious issues. And not getting pregnant within 12 months of trying would be considered infertility. After about the age of 35 to 39, because we know that egg quality declines with age, we don't let patients try up to a year. We'd say start getting tested or see someone within about 6 months of trying. And because we know things get especially challenging at age 40 or above, as miscarriage rates also go up significantly at that age related to egg-related aneuploidy, we would recommend being assessed immediately so that you're really hitting the ground running, even if there's nothing wrong on testing, so that at least you have a good understanding about where your egg reserve lies.
Why is asking about the duration of trying the most important first question, in your opinion?
We know that the general rates of infertility in Canada are about 15%, or in general, about 1 in 6 couples will struggle to conceive. The longer someone's trying, the harder it gets. And so most couples, when they do start to try, conceive within about 3 months. So in fact, about 50% of couples will conceive within about 3 months of trying. About 70% will conceive within 6 months, and 85% will conceive at 12 months. And once someone's tried for up to 24 months or 2 years, over 90% will conceive. And so just because someone's been trying for a year and hasn't gotten pregnant doesn't mean that there is a serious issue, but at the same time, it definitely warrants testing, because you know from the statistics and the population data we have, it won't get any easier. And so to tell someone just to keep trying might be reasonable based on their values of wanting low intervention, having no risk factors, having a reassuring workup, and being of a younger age. But it's not the best treatment in terms of getting pregnant the quickest after that diagnosis has been made. And so if I see someone and they've been trying for 5 years, my approach to counseling them is going to be much different than if they've been trying for 3 months. That's really when it comes down to asking about family building goals, family size, and that's when we start talking about serious fertility treatments.
So when we were saying like a patient who has zero risk factor, we have like a different approach to it. What would be kind of the red flags for female, but also for male partners?
That's a great question. So age is always a big one. And that's often known before we even see the patient, as it's on their chart. And I think that we are all very well versed in the unfortunate biological clock for female fertility, or those of egg providers. We know that egg quality and egg count start to decline at about 32 to 33 years old. There's a bit more of a bump at 35, and then a pretty steep decline between 37 and 38, and then another steep decline after age 40. So if someone's over 35, it does certainly raise some flags. In terms of menstrual cycle regularity, so I always think of the menstrual cycle as a vital sign. So No one necessarily follows a textbook 28-day menstrual cycle, but in general, it should be regular and it should be predictable. So on average, about 24 to 25 days to up to 35 days apart is considered to be average, with about 28 days being like the textbook example. We know that the menstrual cycle is divided between a follicular and luteal phase, for which the luteal phase is generally more consistent at 14 days, and so it's the length of the follicular phase that changes. If someone has a regular cycle, it's pretty predictive that they are ovulating. So if someone's coming to you with unpredictable cycles, oligomenorrhea, cycles over 35 days apart, or absent cycles, that's not someone who should try for a year. That's someone who really needs immediate assessment, especially from an endocrine perspective. Furthermore, if their cycles are extremely painful or they have painful intercourse, these could be signs of endometriosis, or very heavy cycles or bleeding between their periods or intermenstrual bleeding. That could be a sign of intrauterine pathology or cervical pathology. You want to ask about STIs or history of pelvic inflammatory disease, because we know that pelvic infections can result in tubal factor infertility or pelvic adhesions. Anyone who's had a previous pelvic surgery, whether that's as an infant or as an adult, so for example, an ovarian torsion, endometriosis surgery, multiple prior C-sections. Someone may have been exposed to medical treatment earlier in life that was gonadotoxic. So for example, a cancer treatment, chemotherapy, radiation. This is a risk factor for lower egg reserve. And then, of course, extremes of body weight as well, because that can cause fluctuations in the cycle. For a male patient or a sperm-producing patient, age still plays a role, but it's a bit less important. But we do start to worry about advanced paternal age after about the age of 40. And we know that there are some risks associated with advanced paternal age that are often not discussed. So miscarriage rates can be higher due to advanced paternal age because of DNA quality reducing. But there's also an association with increased rates of autism, single gene disorders such as achondroplasia, schizophrenia, and certain other aneuploidies. If I have a male patient who's had a history of undescended testicles, that raises some alarm bells, or someone who's had an inguinal hernia repair or general urinary surgery, just like with female patients, radiation or chemotherapy. And sperm is especially sensitive to recreational drug use, whether that is marijuana, alcohol, tobacco, nicotine, even excessive caffeine. And one thing that's often not discussed enough is recreational testosterone use or the use of anabolic steroids. Testosterone itself, as being a steroid hormone, when someone takes it externally, it causes a negative feedback loop on their hypothalamic axis, where their own GnRH is shut down, follicle-stimulating hormone, luteinizing hormone production is shut down, and it actually can inhibit sperm production and cause what we call azoospermia, or no sperm in the ejaculate.
I think this was great because we tend to sometimes focus on the female risk factors, and we forget that, the male risk factor can also impact the goal of conceiving.
I'd say one of the larger myths in the fertility world is that infertility is a female issue. It's an egg issue. That is incorrect. And in fact, it's essentially about 50-50. It takes eggs, it takes ovulation, it takes open fallopian tubes in a uterus, but it also takes normal sperm. And the process of spermatogenesis is complex and largely related to the health of that individual male. And we know that abnormal sperm doesn't just mean it's harder to get pregnant, it can be harder to stay pregnant. And there's growing research to say that DNA damage or double-stranded DNA breaks within the sperm are associated with an increased risk of miscarriage or fertility treatment failure.